All right, I think we'll go ahead and get started. Thanks everyone for making it over here today. It's nice to see some familiar faces in the audience. We're going to be here today talking a little bit about prolonged grief as a biopsychosocial system, trying to understand the different biological and psychological and social components that all feed into this system that gives rise to prolonged grief. And I think this is a really valuable time to be thinking about this because thanks to some of the people in the audience, we've made a lot of huge gains in recent years in terms of our understanding of prolonged grief, our ability to diagnose it, our ability to treat it. But I think there's still a lot of room left for us to consider in terms of thinking exactly through the etiology of this condition and how it develops and how we can best then support people through those experiences. And so we're really fortunate to have some great speakers here with us today. We'll begin with Dr. Mary Frances O'Connor, who's going to be talking with us a little bit about this biological side of things, talking through how different biochemical, neurobiological, and behavioral levels of analysis work together and contributing to some features of prolonged grief. Dr. Matteo Malgaroli will then present some work using natural language processing and speech analysis to identify digital biomarkers. Sydney Friedman will talk with us a little bit more about the psychological level and talking about the impact of the COVID-19 pandemic on bereavement-related outcomes. And I'll take on a little bit more of the social level, thinking about how social interaction factors in to our experiences of prolonged grief. And then we're really fortunate to have Dr. Naomi Simon with us today, who will, I think, have the most challenging job of all of trying to think through how all of these things work together and contribute to prolonged grief. So with that, I'll let Dr. Mary Frances O'Connor start us out.
Thank you, Don, and thank you for being our fearless leader, pulling this symposium together. It's always more work than one imagines it will be. All right, so I am Dr. Mary Frances O'Connor. I'm at the University of Arizona in the clinical psychology department. And so, as Don said, I'll be talking about behavior, affect, and oxytocin today. I have no disclosures relevant to this talk. And I like this particular slide that I shamelessly got from Google because many of us still think about Psych 101 when we think about grief and the 5 stages of grief that Elizabeth Kubler-Ross started talking about in 1969. And so if you learned about grief from Psych 101, you might expect the experience on the left. And if you learned about grief from personal experience, you probably understand it more as the experience on the right. But I want to talk with you today about prolonged grief disorder. I'm not going to go into the details of how we diagnose it, but I am going to give you a way of thinking about it that may be contrary to how you have previously thought about it. So, research shows that for the majority of bereaved people, grief decreases across time. And this particular study by Manik Jelantic and Don Robinaugh and Paul Bolin, Dutch researchers, they looked at a group of grieving people and they actually measured the same person at many time points across the first 2 years of grieving. What they did then was they asked not how much grief each person was having, but what was the trajectory of their grieving. So the idea here is that grief and grieving are actually 2 different things. Grief can be assessed sort of in the moment, how much grief, 1 to 10, but grieving means, is it getting better? Is it getting worse? How is it changing over time? What you can see is that 2 of the trajectories that were developed, analyzed from this data in a latent component type analysis. The blue and the green line show us that, again, for the majority of people, there's a decrease in grief over time, although you'll see that the scale does not go to 0 per se. It is not that individuals ever stop experiencing grief. Grief is just a natural response to loss. We're no more going to stop feeling grief than we're going to stop feeling anger, or we're going to stop feeling sadness at some point. The group that we worry about, of course, is the group in red, here listed as chronic grief because this wasn't diagnosed from a clinical perspective, but demonstrates that there is a trajectory of people grieving where you don't see change over time. What is most important to me about this slide, let's see if you can see my cursor. No. Okay, let's see if you can see my pointer. You can. So this is too tiny for you to see, but this is 12 months here. So what I like to point out is that before 12 months, if someone walks in and tells you how much grief they're having, it's really hard to tell what their trajectory will look like. After about a year, you start to see these lines separate. And so if after a year they come in and their grief has not changed, you can predict potentially that they will stay on the same trajectory. If in fact you have started to see a change, not that their grief is particularly low, but you can expect to continue to see a change. And I like to think about this in terms of why we don't diagnose prior to a year, because we have no idea what the trajectory looks like yet for this individual. Now, one of the hallmark symptoms in prolonged grief is the yearning for the person who has died, the wanting them back, the wishing things were the way that they were. And in my own work, I've spent a lot of time thinking about, where does this yearning come from? Why do we have such yearning? I come at this from a very cognitive neuroscience perspective, not the first thing people think about when they think about grief. And I think about what it is to adapt. What is it that we have to understand when a loved one dies? We have to understand the reality that this person is gone. And of course, we have a system in the brain that enables us to do this. We have a memory system. We may have a memory of being at the bedside when a loved one died, or being at a funeral or a memorial. Our memory system can recall and can tell you that this loved one has died. On the other hand, we also have attachment neurobiology. When we bond with our one and only, when we fall in love with our baby or we fall in love with our future spouse, that comes with an implicit belief. I will always be there for you, and you will always be there for me. And it's the always part that is very deeply encoded, in the sense that if someone's not in your presence, your living loved one has gone off to work, or let's say they've gone to a conference, we don't assume that they are no longer available simply because they are not in our presence. What it means is that when a loved one dies, it is very difficult for the brain to update its predictions that this person is actually gone. And so while these cannot both be true, they are still an everlasting person in the world, and also they are gone. When we're aware that both of those cannot be true, we experience this yearning and grief. And it takes us a long time to learn to predict that they are no longer going to be in the room. Or at the end of that text message, we pick up and then think, oh, I can't text them anymore. So yearning is this intense, maybe unsatisfied, appetitive desire for this loved one. It's really a motivational state, but of course that then contributes to the way we think and feel about what's happening. Yearning has this important function when we have a living loved one because it reminds us to seek them out, to reunite with them, to provide care and receive care from them. So at the end of the day, the way I think about it is you can't really understand grief and loss without understanding love and attachment, because it's the attachment bond that is no longer there, that's been broken. So what do we know about attachment bonds in the brain? So with living loved ones, we know that the brain uses dopamine and opioids and oxytocin, very powerful neurochemicals, to motivate us to seek out our loved ones. And these neurochemicals are found in specific brain regions that are important in reward learning, including areas like the caudate and nucleus accumbens. So these are too small for you to actually see the brain blobs, but that's okay, trust me on this. This is 3 pictures, 3 different MRI studies. Women looking at photos of their infant, men looking at photos of their kindergartner, and couples looking at photos of each other in that last study. And they're all showing that with living loved ones, they're using this basal ganglia, this caudate nucleus accumbens parts of the brain that are important in reward learning. Now, some years ago, I did a study where we looked at people who were grieving and showed them photographs of that person who had died. So this is an idiosyncratic, right? It's specifically, they're looking at the person with whom they are attached who has died. And what we found was that there was a particular part of the brain called the nucleus accumbens that correlated with how much yearning they told us they were experiencing prior to the scan. So that is to say, the more yearning they had, the more activation they had in this region. So we know that nucleus accumbens and reward learning are important both in bonding and also in what happens during grieving when we continue to yearn for this person, to want to seek them out again. So one of the problems clinically that we've thought about is whether prolonged grief disorder is partly about approach, wanting the person, or is about avoidance, actually avoiding reminders of the loss. Now, of course, it doesn't have to be either or, but the challenges that we saw initially were that in PGD, we saw problems with both. So we see this seeking reminders and yearning for the deceased, but also avoiding reminders, behavioral avoidance, avoiding the feelings of grief. And these avoidance and approach behaviors can both become excessive, meaning that they're very disruptive of the person's functioning. Now, when we started this study I'm going to report on today, experimental tasks had used a variety of different stimuli to try to get at this question of how bereaved people were demonstrating approach and avoidance. And in part because they were using different stimuli, it was hard to sum across the studies. Some were using grief-related words, some were using the name of the person, so we didn't really have a good sense. And we wanted to do a study where all the kinds of stimuli were in the same study so that we could see within this individual, how are they responding to different kinds of reminders. And so in this study, we used what's called the approach avoidance task. This was 39 older widows, which I will say was powered by fMRI and not powered by a behavioral study. But I'm going to talk about the behavioral results today. These individuals came twice, so it was a within-subject design. People served as their own control, a week apart, in a counterbalanced, double-blind way, where they either received oxytocin intranasally or a placebo, a saline intranasal spray. We used, as I said, a whole variety of stimuli within the study. So we asked for a photo of the deceased person. We also asked for a photo of a living loved one to account for things like familiarity. We then provided a photo of a stranger, someone they had not met before. We used grief-related words, and those words were then the same across all bereaved participants, and matched those with neutral words. So we have this whole host of different stimuli within the same study. And we're very interested here in the automatic responding. So this isn't the conscious decision about approach and avoidance, but simply what do people do? And we used this joystick, like an Atari joystick, for those of you that are of the appropriate age. And what that means is the photo would either back away from them, like avoidance, or would come toward them, like approach. So let me show you a little bit what that looks like. So it was smoother in the actual study, but the idea is if you pull the joystick towards you, the picture gets bigger, which is a demonstration of approach. Now, what they were told to focus on was the frame surrounding the photograph. Most people did not experience the cute bunny. Obviously, these are different emotionally evoking stimuli. But by focusing on the frame, we were actually able to see people's both pushing and pulling. So it was pull for blue in this case, and later in the study, it would be push for blue. By having both of those, then, we can compute an approach or avoidance bias. Do they pull faster or push faster for this type of stimuli? All right? So what I'm going to show you now are results from the study, but there's lots of different ways to break this up since there's so many components that I told you about. So in the beginning here, I'm just going to show you, this is everyone in the study, and this is just during the saline, right? So no oxytocin involved. This will give you a sense of what most of the result slides will look like. So at the bottom now, we have the different kinds of stimuli: grief, neutral, stranger, living, spouse. And what we see on the y-axis is that the 0 point would be if they were exactly the same in automatic responding, pushing and pulling. Fortunately, the neutral and the stranger, which are meant to be sort of the control conditions, look pretty neutral for people. What we see is an avoidance bias across everyone for the grief-related stimuli. And we see an approach bias for the living loved one and for the deceased spouse. So this was partly helping us to make sure that it was working the way we thought it was working, and now we can break it down a little bit further. That's what I said. All right, so in this slide, we have the same stimuli across the bottom, the same approach avoid bias, but now I'm showing you the two groups of people in the study: those with prolonged grief and those who did not have prolonged grief. Prolonged grief is in blue, and typical grieving is in yellow. And I think one of the most obvious things when we first look is that across all the types of stimuli, people with prolonged grief are more avoidant. So it doesn't even matter what we show them, they are more avoidant in general. I think the other thing, though, that is important to notice is that the slope is the same. So they're still showing the most avoidance for grief and the most approach for the deceased. Just like everyone else, it's just that the whole system is shifted toward avoidance. Now, in this slide, what I'm showing you is the difference then between the placebo condition in blue, in red, and the oxytocin condition in blue. This is collapsed across stimuli. And so what that looks like is, in the placebo condition is the collapsed version of what I showed you before. People without PGD show more approach to all stimuli. And in the red under PGD, those people are showing more avoidance across all the stimuli. If we look at then how that changes when we look at providing oxytocin to them, the PGD group becomes less avoidance biased when they get oxytocin. So, and actually, although it may look like it, this is not a statistically significant difference, but this is a statistically significant difference. So the first take home there is oxytocin is having a differential effect on people with PGD. It is also changing the direction of their automatic responding in the approach-oriented direction, and not changing the directional behavior of those without PGD. Now, what I'm showing you here is just the responses to the spouse stimuli. Obviously, we care a lot about the spouse stimuli because that's the person who presumably is evoking the grief. And what we see here is that in just that case, we have, again, no statistical difference in responding to the spouse photo for the typical grieving group, regardless of whether they got saline or oxytocin. But in the prolonged grief group, we see this increasing of approach behavior or a decreasing avoidance behavior in those with PGD. Now, on one hand, you might interpret that as a normalization, right? Now they look more like people with typical grief. But I would actually caution against that interpretation. So if we think about what people are doing day to day as they are ruminating about the deceased person, would we really want to increase approach behavior in someone as they are having this rumination about the deceased loved one? We might want to increase approach behavior when they're with a stranger or a living loved one, but oxytocin doesn't work that way. If you're just giving it in the daytime, we don't know which things it will be changing motivation around. So for this reason, it really was just a probe in this study. It was not meant to be in any way therapeutic necessarily. All right, so just to summarize here, just to point out that yearning is very effective when people are alive. It is a part of the attachment neurobiology. And most bereaved people, as they adapt, do show a decrease over time. But people with PGD are not showing this typical adaptation. Avoidance of reminders of the death can interfere with that learning process in grieving and prevent them from being able to update their predictions that this person will no longer be there. I think this study uniquely perhaps points out that PGD may arise or be maintained because of oxytocin mechanisms that may affect this approach and avoidance behavior. But I will say this is, of course, very chicken and egg, in the sense that this is a cross-sectional design. We don't know if there were pre-existing oxytocin differences in individuals before the death of a loved one, or if those arose in consequence to the loss of this person. So future research should really try to use those longitudinal designs. I want to thank the funders for this type of work, and of course the bevy of graduate students that it takes to run these studies, and to thank all of you for coming today. Thank you.
Okay, so thank you everyone for being here. My name is Matteo Malgaroli. I'm an assistant professor in the psychiatry department at the NYU School of Medicine. And what I'm going to do today, I'm going to talk with you about some aspect about loss narratives, right? With the idea of like how people describe their own experience of a loss. And I'm going to use and show you some methods in which we can analyze this for a better understanding of longitudinal outcomes in grief. I want to start by saying there's no relevant disclosure to this, and let's begin. So I think that the first thing to think about when we think of bereavement and loss is that this is a fundamentally human experience. This is a normal condition. It is so ingrained in what we define as living that the very first thing that was ever written that we have proof of, which is the Epic of Gilgamesh, is basically a story about grief, bereavement, and coping with the loss, right? So there is an idea of how we discuss about grief experiences that is intrinsically human and intrinsically meaningful. When we think about this, since it's such a common experience, it's also important to think about how do people cope normally, right? If this is such a normal experience, in what cases, in what proportions do people not cope well and they develop what we now call prolonged grief disorder? Well, when we look at longitudinal studies, and I love that Mary also showed you some others of those just earlier, we can see that the model outcome tends to be a good adjustment, right? And this has been proven across multiple studies in multiple settings across different types of bereavement and losses. That said, though, we know that about 7 to 10% of people who experience a loss will actually develop pathological symptoms, what we call now prolonged grief disorder, right? And even if this seems like a small number, let's run the math very quickly, right? So just in 2017, so the time before COVID, we know that the number of deaths in the US was almost like close to 3 million. So when we think of 7% of that in such a large population, it means there's a large number of people who could be at risk of maladaptive adjustment to the loss, right? That's a very large sample, and these things are important. In addition to some of the things we know related to prolonged grief disorder as per the DSM-5 TR definition, and many of my colleagues here today will tell you more about that, what you may not be aware of is that people who experience poor adjustment to bereavement actually are more at risk at experiencing suicidal thoughts and behaviors. Right? This is something that actually in the early stages when we were still trying to define the best way to describe prolonged grief as a psychiatric diagnosis, the idea to wanting to die in order to join the deceased was considered to be a symptom. Right? And it is considered a symptom because it's very intrinsically part of the idea of like death and losing meaning and not knowing what to do with life anymore, right? So these are elements that are intrinsically part of the experience of being exposed to loss, particularly for suicide survivors, right? We know there's really a lot of literature that I really recommend you to look at it if you're interested. Right? So not only we have like risk of long-term poor adjustment, we also have acute risk of like suicidal thoughts and possibly even behavior. And at such a large scale, that poses some questions, right? The first thing is that can we identify individuals who can be at risk of this more acute risk, but also long-term? And I think our chair really did a great job to make Mary come first, because also she was saying, based on those trajectory that we just saw, how can we know if people are going to have a good adjustment or bad adjustment, right? As you can see, we need to wait a year when we look at like self-report scales, diagnostically scale. But that makes me wonder, is there a way to capture certain elements at the beginning, like a time where we cannot, from a diagnostic perspective, predict yet poor adjustment? Can we find some elements that we can use to identify people who are more at risk, right? Not certainty, right? Probability, want to make it clear. And another element, can we do this with methods that are scalable, right? Instead of giving everybody a questionnaire, instead of everybody going to a clinician, can we leverage this technology as a way to really try to reach as many people as possible in a possibly also passive way? So what I'm going to present to you now is a pilot also generally funded by FSP to try to measure these elements. I'm going to show you a very complex graph for a second. I'm going to get down to it. But the idea is that what we did is that we took a series of samples of loss narratives, right? So these are people who just recently bereaved, who talk about their experience of the loss and sometimes even shortly their life since after the loss. And we have recordings of this across various samples. What we did with this, we did some computational analysis, which I will describe to you in a bit, to see if this can help us predict two important elements. As I said, acute risk, as identified by suicidal thoughts and ideation, and then also their long-term adjustment, right? Now, there are three questions that I want to follow up for a bit before I show you the result. The first thing is that why are we using loss narratives as a form of data? The second element is like what kind of studies do we use to train these computational methods, right? Because maybe not all of you are familiar, but it's very important to understand what kind of data you're using to build this kind of models and also to test them after, right? Because we want to make sure that these things are ecologically valid. And the third term is also like what kind of elements did we capture, right, from these interviews, from this recording, what use did we make them, and what makes them unique compared to other types of adjustment that are measured computationally. So the first element is that probably this is the easiest part with this audience who's like very clinically familiar. The idea that we know that many elements of like maladaptive adjustment can be captured from narratives because they have to do with identity disruptions, loss of meaning, emotional pain, yearning, like all things that can really be manifest in the way that somebody describes a story about the loss. And we know for a fact that actually the use of like discussing about the loss is a very important therapeutic element in therapy exactly for this reason. And also another element is that as clinicians, when we interact with patients who may be at risk of like grief-related pathology, the way they describe the loss carries a lot of emotional and cognitive elements that we can capture and then use for diagnostic purposes, right? So loss narratives in other ways is something that feels very natural when it comes to describing about the loss. There's a lot of like very clinically rich material, and it makes it really useful as a possibility, as a surface in which if we want to define new ways to measure adjustment to loss, this seems to be naturally the case. Also, I want to also mention that this is not something that I design out of nothing. There's a very abundant literature in ways to use open-ended narratives about traumas as a way to predict adjustment. This, for example, is a case shown by one of my colleagues at NYU, Katharina Schultebrauch, where we can see that like semi-structured interviews or even open-ended narratives about people discussing about their traumas can show predictive ability for adjustment over time, right? So there's something that really makes sense. Again, let's think it clinically, a lot of meaning making, a lot of cognitive elements are really capturing the way we describe an event that can be potentially traumatic to us. Because if we got this clinical side, the rest is not as magical. In terms of the data we use, there are two main data sets. As I said, when we do this machine learning or AI analysis, it's very important two things. The data we train on, our models, and then the data we evaluate it on. And to do so, we try to use two very different data sets. The main model was trained on a larger data set of an epidemiological study. This is called the Pearl 2 that was done at Columbia University with George Bonanno. And it's an epidemiological study where we have an adult group of spousally bereaved people followed from 3 months after their loss, so very early in the bereavement process, 3 months after their loss, up to 2 years after. So adjustment was measured over time. We know who adjusted to the loss and who didn't. And among those 350 participants, we capture 180 interviews, like recordings of interviews where we have both transcripts and also audio that we use for our analysis. Another element that we try to validate on is what is called the HEAL. Like, I think the other people here in the room should talk about this much better than me. But just to put it briefly, this was a dual, like a randomized controlled trial where they tried to study methods to treat prolonged grief disorder. And what is important here to know that this was a treatment that was done for 20 weeks. There's about 400 participants. And we used them to calculate general trajectories about these outcomes. And if you're interested to hear how these trajectories were done, Adam Calderon, who is gonna present this like shortly after the poster panel, so asking more questions about that if you're curious. But what's important to know is that also in this setting, we know who are the people who were chronic, that despite treatment, they were not able to go beyond their loss-related symptoms. So in other words, just to summarize, we have interviews from an epidemiological sample, which contains clinically relevant patients and also normal population patients. We train a model on this larger sample. Then we validate it on a clinically relevant and clinically symptom level subset to see if it captures symptoms that we care about. Now, the analytic part, I'm going to go relatively fast, but I just want to mention that, as I said, we have this recording, we have transcripts, and we have the audio from these interviews. We analyze the audio through audio processing. This is a relatively common pipeline. It's a software called Pratt. It does acoustic analysis, think of pitch, format, a lot of things that you can normally capture out of how somebody speaks. Right? And something that I care more about, to be honest, so for a biased reason, I'm going to tell you more about, instead the use of transcripts, right? So we captured this transcript and we did an NLP analysis, also known as natural language processing. This is an ability that now we know is getting more and more of the general interest of the general population. I'm going to tell you more about that in a second, but what matters here is that we capture elements that are easily interpretable, so dictionary, vocabulary, use of emotions, and we capture also them with more sophisticated methods, including embeddings of what people were talking about. Right, so we took this lost narrative, we analyzed it computationally, we also took how people talk about their narratives, and we analyzed it through an acoustic pipeline. And I'm going to tell you more about this language model part for just 2 minutes, just so that it doesn't feel mystical. Which is the idea that more and more often nowadays we see the use of natural language processing and AI methods as a way to take transcripts from clinical interviews, clinical therapeutics, digital health interventions, and to process them through NLP as a way to inform us of like some clinical important elements. In our case here, what we're trying to do, we're trying to predict adjustment over time, right? But there's other cases where this has been used to measure therapeutic effects, to diagnosis, response to treatment, therapeutic alliance. There's more and more use of these methods over the course of treatment in general, but also assessment. What I want to show you for 1 second is that embedding part I told you before. So, because when we think about the idea that loss is about also meaning making and loss of meaning, it makes it particularly relevant to use word embeddings, right? The idea that, because when you think about it, you see a text, how does a computer analyze that, right? That's not a question that everybody is aware of course, because this is like very recent progress. And the idea is that if we train these models on a very, very large amount of text, they have a sense of what one word is usually close to one another. Think of the example I made here. Bank and money are going to be sometimes very close because they appear close in the general discussion. And when we project them in a very high dimensional space, their proximity carries meaning. Right? We bank and money are close to one another because they have to do with something about economy, something about dollars, and so forth. Right? So there, in other words, we can create numbers that carry meaning, and then we can perform operations. And one of my funniest example that also like is probably one of the most known is that when we transform words into numbers through embeddings, we can also do operations like mathematical operations that carry meaning. And a typical example is that if we take the embedding of king, remove male, and add female, we obtain the embedding of queen. Right? So this model can capture semantic meaning, and meaning is important for us for assessment. The only thing I'm going to say before I show you the result is that we need an extra layer of sophistication, because we know from language, when we use words, let's say, I will die for it, or like death in another sense, the context really matters. right? So we need models that are a little more sophisticated than watching at words per se, but as a human would do, we need to watch them in the context, right? Particularly for clinically related assessment. So what we did is that we used the embeddings that come from large language models, because those not only look at the word in that narrative, but look at all other words around to update the embedding value. So in other words, to give meaning to a word depending on its context, right? Which is really important for us to do clinical models. So in other words, we use all these methods all combined together to increase our accuracy, but also we use some simpler methods that I'm going to show you in our interpretability to have a sense of what we're looking at. So now that I told you all of this, let's look at the results very briefly. The first thing is that when we try to predict adjustment over time, as you can see from this area under the curve, the model is pretty accurate, right? So we have a 0.81 AUC on the ability from base of 3 months interview to predict adjustment over time in an epidemiological sample, and also non-response in a clinical sample, right? So this is a pretty interesting. Based on how people describe their own loss, we can possibly predict how their adjustment will be. And when we try to look at the elements that actually build the model, so that they inform us of like why the model decided that this person will not adjust versus will adjust, some interesting elements come up, and actually I'm really open to hear from the more clinical audience what they think about this. For example, when it comes to poor adjustment, like differences in pitch variation are what matters. Maybe people were crying, right? This could be an element that we were able to capture automatically. There was much more focus on the present and less in the future in this people narrative. There was a smaller dictionary, less confidence. Right? These are interesting elements that even from a more interpretable level, the model was able to capture. Now, when it comes to suicidal thoughts, when we try to externally validate on the sample from the HEAL study, unfortunately, the results are not as good. So for those of you who know machine learning classification, an AUC of 0.68 is not that bad, but still, the reason why this is not good is because when you look at why the model predicted that based on this narrative, this person could have suicidal thoughts or not, when you look at the numbers of what is called the confusion matrix, actually the model was saying no, like no risk. Because of course, unfortunately, there's a low base rate here. So unfortunately, this kind of influenced the fact that the model was not really good. And we understand that that's not really clinically relevant, right? Because if we remove the risk, then we are never able to capture the people we really care about. I'm just going to go very quickly here because, again, the model is not that effective. Just to mention that, there have been less dictionary, less filler words when it comes to people who are more at risk of suicidality. Something that made more sense in this setting is the use of the I pronoun. This has been shown in depression literature, is connected linguistically to more depression symptoms. So there is something there the model is still picking, just not very well. So to summarize briefly these findings, we can see that we can measure automatically by examining lost narratives the probability of people to adjust well or not, just based on reading the transcripts and the way the people talk about the loss. And this works decently well in clinical and epidemiological sample. Unfortunately, we're not there yet for suicidality, and since this started as a suicidality-related project, I'm still not happy with the results because of that. So I'm going to try to leverage some of these new models, hopefully maybe integrating all of these elements together in the same input can be useful, because again, we're in a place where it's really important for us to try to find new tools that objectively and at scale can help us have people get the help they need, right? This is the only reason why we're doing this, and to help clinicians remove some of the burden that comes with assessment. Before I go, I just want to thank the people at NYU who made this work possible, the founders and also collaborators in this project. Thank you very much. I think we have time maybe for one question. Awesome.
I have a question.
Yeah. Oh. Hey, Don.
Is this on? Can people hear me? Thanks for the amazing talk. I think this is incredible work. Am I thinking correctly that the audio that you're analyzing in the treatment context is the imaginal or visiting? It's the lost narrative. And I wanted to ask a question about the confidence finding. I'm curious kind of what that looks like acoustically. But I guess in kind of reflecting on my own experience in hearing these narratives, it does seem like initially there is a lot of kind of uncertainty in trying to recall exactly what happened and the level of detail that we're asking. And if I understood correctly, you're looking here just at the first imaginal or visiting, I was curious if you have a sense, like, could we use this as a way to track change in confidence over time, like increasing confidence in the narrative?
Oh, that's why you asked me this question before, so now I have the answer. Yeah. So I think that some of the risk with these models is that unfortunately they are very smart and they're very lazy. They're basically humans. So what they'll try to do is they're going to try to get proxies as a way to make these responses fast. What I mean by this is that sometimes they can capture demographics as latent variables and use those variables to predict. Now we know we have 20 years of like psychological research, probably more, where we know that like certain population at risk are more likely to experience symptoms. So I think that will be the only true way when we think of deploying this kind of experimental pilots into reality. We definitely need to have these longitudinal studies, because if only within the same person this variable change enough, then we know that we're doing a right measurement. And we have some studies, also one with DARPA exactly to do this work, because we don't want to distinguish populations, because we can just capture demographic at this point. We want to capture markers within the level we're looking at, right? Because we don't want also to then at a certain point the risk is to perpetrate stereotypes and biases in healthcare, which is not what we want to do. We want to do the opposite. We want to have more people getting more help. Right. Great question. Thank you.
So I'm Sydney Friedman. I'm a fourth-year graduate student with Mary Frances O'Connor at the University of Arizona. And I'm going to talk about pandemic grief, or as we call it, PANGs, looking at acute grief of bereaved relatives following deaths during the COVID-19 pandemic. I don't have any disclosures. Okay, so just starting with a little bit of an introduction. Giving you a brief overview of the impact of the COVID-19 pandemic on grief and loss. So as we all remember, we saw unprecedented levels of loss during the pandemic. As of May of 2023, which was the official ending of the pandemic, according to the WHO, there were over 1 million deaths reported globally, and also leaving millions of people bereaved. I'm going to talk a lot about these different unique challenges that happened during the pandemic, but some of them were social isolation, sudden increase in mortality, and then deaths in facilities without bedside visits. I'm also going to talk a little bit about a comparison with previous tragedies like 9/11, which will really highlight the scale and nature of the loss during the pandemic. And one of the reasons why we did this is because it's one of the previous events where there was some grief research that was actually done by some of the people here. Okay, so talking a little bit about pandemic grief. Grief during the pandemic was novel and urgent. So COVID-19 presented unique challenges and experiences of grief that require us to talk about it and think about it. There were some practical implications. Research on pandemic grief can really inform interventions, as we heard a little bit about yesterday, and support services for bereaved individuals and communities. Also, there's a social relevance, which we'll hear a little bit more about from Don later, but understanding pandemic grief really contributes to broader discussions about resilience, coping mechanisms, and then societal responses to large-scale crises. And then, of course, there's an academic contribution. It's really important that we understand pandemic grief because there's an implication that's really interdisciplinary in psychology, sociology, public health, and other areas. But so today, we really aimed to explore looking at these unique characteristics of grief during the pandemic. Okay, so I'd really like everyone to just take a moment and sort of engage with some of these images, remember what the time was like during early times of the pandemic, in part because, just to remind you all, but also a lot of our participants became bereaved during these times. And so just to kind of put us all back at that time, if you're willing to go there, and think about what this was like. Okay, so some of the unique characteristics of pandemic grief. There was a variable death trajectory for those with COVID-19. People got better, and then suddenly people got worse. There were also a lack of bedside visits in institutions. And I'm going to talk about institutions a little bit, or use the word institutions, and what I mean are hospitals, emergency departments, and long-term care facilities. There was also this widespread social isolation and a sudden increase in mortality rates. And that social isolation, as we know, leads to an increase in psychological distress. And then because of that social isolation, there are changes in coping and social support, which leads to a need for adaptive support services during and after the death. One of the things that we thought about was, well, what can we kind of compare this to that happened previously? And as I mentioned, I was going to talk a little bit about 9/11 and make this comparison. So there were some similarities, but there were also some differences. So of course, COVID-19 was prolonged and ongoing crisis spanning months to years. One of the things just a few days before I came here was I got the newest COVID vaccine. So it's still impacting us. There was widespread illness, and then deaths, often occurred in medical facilities or isolation, which really limited the opportunity for in-person goodbyes and traditional mourning rituals. 9/11 was also a sudden but singular event, and it was concentrated to a geographical area, but it was also impactful. Really the biggest difference was the effect of social isolation that we really didn't have during 9/11 that we had during COVID. So one of the things about the literature was there wasn't a whole lot of literature when we started the study. In fact, I don't think that there was any literature when we started the study. And there still isn't actually a lot. So there's a couple kind of key points I wanted to highlight, though. So Eisma and Tominga found that COVID-19 deaths that were experienced as unexpected led to higher grief severity than natural deaths. This is specifically with acute deaths due to COVID, or acute grief due to COVID versus acute grief due to natural deaths. However, Breen and colleagues found that COVID-19 deaths were not associated with increased levels of grief compared to natural deaths. And then in France, there was a report that that bereaved individuals had an increased distress due to restricted visits and distance communication. And so there are some gaps and inconsistencies. We need to understand, what's going on with grief severity due to COVID-19 versus due to natural deaths. And we also, one of the things that was interesting was that Eisma and Tominga happened to be doing a study at the start of when COVID started, a grief study, and so they were able to look at grief before the pandemic started compared to grief after the pandemic started or during the pandemic. Okay, so for the hypotheses that we looked at here we looked at, of course, cause of death, so dying of COVID versus other natural causes, and its effect on grief severity, where someone died, at home or in an institution. And we also made a focus on expectedness of the death and its impact on grief severity, and also looked at depressive symptoms and daily functioning. This was a mixed methods design, so we had both quantitative and qualitative data. The participants were recruited primarily through what we called the cohort study, a parent study, which was population-based and an epidemiological cohort study at the University of Arizona College of Public Health. And so first, participants who experienced a death, who were part of that study, who experienced a death, filled out an online survey. And then from that online survey, they were self-selected to participate in a semi-structured phone interview about their pandemic grief. One of the things that's important that I wanted to talk about briefly was this measurement of unexpectedness. So normally, unexpectedness of a death or suddenness is measured as a dichotomous variable. Either it was expected or it wasn't. And measures assess the survivor's overall perception of expectedness, or when the survivor realized that the death would occur. And this can really vary and be as little as an hour. But because COVID had such a variable trajectory, sometimes people, as I said, would get better and then suddenly they would get worse. We really looked at expectedness as a continuous variable. So we looked at it at a year, a month, a week, and a day. And then we created this variable by summing that being from 0, totally unexpected, to 4, continuously expected. Okay, so now looking at a little bit of the results. We had 61 bereaved adults who went through this interview, the average age of a little bit over 49, mostly non-Hispanic white, 39 females and 19 males in terms of gender, and 3 reported other as gender. 33 deaths were due to natural causes and 28 were due to COVID-19. The average loss was about 1.5. Average number of losses was about 1.5, but the most was 8. 39 loved ones died in an institution and 21 died at home. So there wasn't, what we found for starting with cause of death, there wasn't any significant relationship between cause of death and other natural causes and an individual's grief severity or depressive symptom severity or their daily functioning. Also, location of death. There wasn't any relationship between where someone died and its impact on their grief severity, depressive symptom severity, or their daily functioning either. However, expectedness of the death was impactful. So unexpectedness of the death was associated with higher grief severity and higher depressive symptom severity. But also, interestingly, there was no significant association between how expected the death was and their daily functioning. I also have a note here on how we tested these models and accounted for age, gender, and time since loss and determined the most parsimonious model. Okay, just wanted to check the time. Okay, so getting into a little bit of the discussion. So as I said, unexpectedness was pretty important. It was definitely associated with someone's grief and depression, but it was not. It did not, or excuse me, their grief and depression was not impacted by the location of the death or the cause of death. And our results are inconsistent with what Eisma and Tominga found from 2022, but our results corroborate what Breen and colleagues found. Something that was interesting was that, I already said this part, sorry. Ultimately, really, there's a high need for future pandemic preparedness. One of the things that we know is that due to climate change and that viruses are getting smarter, there's likely going to be more pandemics, and we really need to use the information that we have and the knowledge that we've gained from this most recent pandemic to help us prepare for what's to come. I also wanted to give you a little bit of an idea of what some of the participants said in the interview. So I'll just read some of these. So someone said, "Not being able to have a memorial service has been hard. I feel like that's maybe why things haven't sunk in yet. It was like she was here and then she just wasn't. There was nothing really that made her death seem real." Someone else said, "The only significant factor was not having a large organized service. Under the circumstances, it was actually better having a small casual gathering of only our small family." And then this one that didn't fit on the slide was, "My grandpa had dementia and was in a nursing home. He was moved there 2 weeks prior to the lockdown, and the staff told us that he didn't understand why family didn't come visit anymore, and that he felt abandoned. Knowing that he felt like we abandoned him has been the hardest part." So that's my brief wrap-up on pandemic grief. I want to acknowledge my lab, the Institute for Mental Health Research Grant, We had some great statistical consultation by Dr. Melissa Flores and Savannah Boyd. And then, of course, many thanks to the participants of this study. That's it. I don't know if anyone has any questions. So the question was, what percentage of participants from the parent study agreed to be interviewed? Am I understanding that correctly? I actually don't have that data right offhand. Mary Frances might remember.
Gosh, I'm trying to remember how many were in Sovicore and how many were in pain.
It was a pretty small percentage of people who compared. I mean, there were
30%?
Yeah. Okay. Yeah. That sounds.
About?
Yeah. Around 30% or so. Yeah. Any other questions? Yeah. No. Okay.
All right. So today I will be talking again a little bit more from this social level of analysis, thinking about the role of social interaction and how it interacts with our psychology and contributes to prolonged grief. And I have no disclosures, but want to acknowledge that this work was supported by funding from the National Institute of Mental Health. So if we adopt this social perspective, then I think we can really think about bereavement as a very severe disruption to one's social network. So if we consider this small and overly simplified social network here, if we think about bereavement in that context, it's a really profound stressor on this network that affects it in a few really crucial ways. One is what we heard from Dr. O'Connor in talking about attachment bonds and the separation of that attachment bond with, in this case, a spouse. But in many cases, the impacts go beyond just that alone. In many cases, we also lose connections to people who are in our social network because of their connections to the person who died, and we lose those relationships in some cases over time. And in many cases, the people to whom we remain close are themselves affected by grief, and that's something that can strengthen those bonds, but can also strain them and lead to challenges with those relationships over time as well. And given this really enormous disruption to our social networks, I don't think it should be a surprise that bereavement confers a really substantial risk for loneliness, that aversive emotional experience that arises when our social needs are not being met. And I think that this is really crucial for us to consider because loneliness confers risk for a host of mental and physical health challenges. Almost anything you can think of is going to be at greater risk in the context of heightened loneliness. And of particular relevance to this symposium, loneliness is associated with increased risk of depression and prolonged grief following bereavement. So this figure on the right here is from a study that I particularly like by Eiko Fried and Margaret Strobe and others. And in this study, they looked at how loss relates to different components of the depression syndrome. And so each line between our different symptoms here represents a conditional dependence relationship. And essentially what you can see in this network is that our loss variable at the top, its relationship to the rest of the depression syndrome is essentially mediated by loneliness. It's conditionally dependent on loneliness. So when people are experiencing loneliness in the context of loss, it's really something that makes them much more vulnerable to the broader syndrome of depression, and as, again, we know from a good amount of research, also to prolonged grief as well. So given this crucial importance of loneliness, I don't think it should be a surprise that there are a few dozen studies looking at loneliness in bereavement, and the majority of these studies have used standardized self-report questionnaires. So for example, the questionnaire depicted here is the 3-item UCLA loneliness questionnaire, and you can see that it's asking different questions related to social connection and loneliness, and asking how often you had these experiences, from hardly ever to some of the time to often. And among the remaining approaches, many studies used a single-item assessment of loneliness, and typically this was done by drawing one item from a larger scale. So this is the final item of the inventory of complicated grief, and asks people to report the extent to which they felt lonely ever since the individual died. And again, we're rating things on a scale of never, rarely, sometimes, often, or always. So together, these two approaches make up about 90% of the research on loneliness and grief and loneliness and bereavement. And you can see that while there are slight differences in the number of questions, these questionnaires are taking roughly the same approach to assessing loneliness. They're both focusing on retrospective self-reports, so they're asking people to reflect over the past week or over the past month and think about loneliness over an extended period of time. And they're also focusing on loneliness frequency. So that's their primary focus in assessing loneliness. And because of that, that means that loneliness frequency is most of what we know in the loneliness and bereavement literature. So while this has proven incredibly valuable as an initial effort to try and understand loneliness and its relationship to grief, I think there are three really big problems in terms of how much we can learn from these assessments. The first is the problem of recall error and recall bias. So there's a very large literature making very clear that when we ask people to reflect over an extended period of time on their experiences, they are prone to recollection errors. And I think in just reflecting kind of critically on doing this, it's immediately clear how challenging this is. If I asked you to just think about the past month and tell me how often you felt thirsty or how often you felt excited, you can see that to really get a good estimate of that would be just almost impossible. I don't really even know how you would go about doing that. And so it's a real challenge, I think, in these assessments. These assessments also provide relatively limited information. Again, almost everything that we know about loneliness in the context of bereavement is just focused on frequency. And it's not even an especially detailed level of information about the frequency. It's, never or sometimes or often, these kind of broad frequency domains. And so we've got relatively limited information about the experience of loneliness in the context of grief because of this. We know that the frequency is elevated, and that's about it. And I think the final limitation is that relying on this approach means that we're largely limited to examining between-person correlations of loneliness rather than within-person correlations. And this is a problem because between-person and within-person correlations are not the same thing, and the conditions under which we can assume that between-person correlations are going to translate to the level of the individual and how things relate within the individual over time are really very rarely met in psychology. So just to illustrate this point, to make sure it's clear kind of what the idea here is, I'll just have you briefly consider the relationship between typing speed and typing errors. So I think it's fair to say that better typists are likely to both type faster and make fewer typos. And in contrast, people who are poor typists might make lots of errors and type relatively slowly. And so if we conducted a study and looked at the correlation between these variables, we would expect to see a negative correlation between typing speed and the number of typing errors when we're looking cross-sectionally between people. However, at the level of the individual, there is a positive relationship between these variables. The faster a person types, the more likely they are to make errors. And so even though we have this positive relationship for every individual in this population, when we look cross-sectionally at our population level data, we draw the opposite conclusion about the relationship between typing speed and typing errors. And I want to suggest that this is not just an arbitrary example, and again, underscore that this is something that I think is increasingly a challenge that we face in this field about the need to think more in this intra-individual context and make sure that we're not only looking at these cross-sectional inter-individual analyses. And if we want to get this additional information about within-person relationships, then we need to take a different approach than we're getting with our cross-sectional self-report measures. And the approach we took in this study that I'll share today is looking at ecological momentary assessment, which essentially just entails repeatedly assessing an experience as it unfolds over time in the context of people's day-to-day lives. And it has three major advantages. The first is that it limits that recall bias. We're asking people to just report on how they're feeling in this moment or how they've been feeling over the past, a couple hours. And so we're limiting the impact of that recall bias or error that's present in these reports. It also means that we have the opportunity to look at really rich time series data. We can see how a process is unfolding over time and look not just at its frequency, but other characteristics of that time series. And then again, it gives us an opportunity to look at within-person associations. So seeing how for a given individual, when they are exhibiting one elevation in one variable, do they exhibit elevations in another, and so on. And we wanted to see if we could leverage these advantages of ecological momentary assessment to carry out 3 aims. The first was to investigate the dynamics of loneliness in bereaved adults. The second was to look at the within-person correlation between social interaction and loneliness. And the third was to evaluate whether the dynamics and correlates of loneliness vary as a function of prolonged grief symptom severity. So to explore these questions, we used data from 144 bereaved adults who participated in a study of prolonged grief. Participants were predominantly white and female, and so something to keep in mind in considering the generalizability of these findings. And all of our participants were between the ages of 18 and 65. The most common cause of death was an illness lasting greater than 1 month, so something like an extended experience of cancer. And the second most common was illness less than 1 month, which would be something like a heart attack. The median time since loss was about 2 years, and by design in this study, 50% of our participants had elevated prolonged grief symptom severity, which we defined as an inventory of complicated grief score of 30 or higher. So participants in this study completed an initial visit in which we did some clinical assessments, and then they did 17 days of ecological momentary assessment where they were using their phone to report on their experiences of grief 6 times a day, every day for those 17 days. And then they came back into our offices and completed another set of self-report and clinical interview assessments. And each day, again, during these ecological momentary assessment periods, they were completing these 6 assessments that came into their phones via text message, and they came in within 6 windows. So they were kind of randomly assigned within these windows to get these survey prompts. And together, then, that provided us with 102 assessment points over the 17 days for each of these individuals. At each assessment point, participants completed a 12-item survey in which they rated the extent to which they were experiencing the thoughts, emotions, and behaviors that we think of as being important parts of grief. And they rated each on a sliding scale of 0 to 100, where 100 represented a maximal level of that experience. So today I'll be focusing on the social activity variable and our loneliness variable. So in the context of loneliness, a score of 100 would mean the most extreme loneliness you've experienced. And on the social activity variable, it would be complete engagement in that activity. So overall, people were really adherent to these EMA procedures. Over the course of the study, 6% withdrew, so we retained 136 of our 144 participants. And among that 136 individuals, the mean survey completion was 94%, and the median was 97%. So you can see in this figure that our individuals with elevated prolonged grief severity had slightly lower adherence than those who were in the low prolonged grief symptom severity group, but by and large, both groups of individuals are very highly adherent to the surveys. And I'll just briefly note that we also found that people reported this assessment approach to be very acceptable. The surveys were easy to use, the frequency was acceptable, the number of items within the surveys was acceptable, and they generally disagreed with notions that this was especially burdensome or caused a lot of distress. So what these longitudinal data allowed us to do is to investigate, again, the dynamics of loneliness and how loneliness is evolving over the course of people's day-to-day lives. And because of the richness of the data, there's lots of ways you can look at it, but for today I'm just going to focus on 4 indices to try and give us a sense of these time series. So the first is frequency, which I'll just define as the percentage of surveys in which people reported at least some loneliness. The intensity of the loneliness, which I'll define as the mean loneliness when loneliness was greater than 0, so when they experienced it, how intense was it? The standard deviation, which is a time-independent index of variability. We just take all of their scores and look at how variable they were. And then the probability of acute change, which represents a time-dependent measure of just how much things are changing from one time point to the next, and in particular, the percentage of time in which there's a big increase or a big decrease in the level of loneliness that they're experiencing. So I'll just go through kind of 3 prototypical time series to give you a sense of what we can see with these data. So this is an individual that I think represents what many of us probably think about when we think about loneliness. Loneliness is infrequent. In this case, it's coming up about 20% of the time. When it does happen, it kind of comes up, it's relatively mild in intensity, and it quickly subsides. By within 2 or 3 assessment points in most cases, the individual has gone back to a state of zero loneliness. There's some variability, but the extent to which people experience big changes is relatively low. This individual is representing, again, kind of another kind of prototypical response that we saw where loneliness is more frequent. In this case, 85% of the time that we asked them, they reported they have at least some loneliness, but the intensity is relatively mild. So their rating is on average at about a 26. And there's a lot of kind of variability in their experiences. So sometimes they're up as high as like 50 in the intensity of their loneliness, but there's also times when they don't feel lonely. And so there's a lot of variability for this individual. In contrast, this is an individual who is experiencing loneliness 100% of the time. Every time that we checked in with them over the course of 17 days, they reported that they were having loneliness and that the average intensity of that loneliness was somewhere in this kind of moderate to severe range. Again, 100 here is the most extreme loneliness you've experienced. And so at 57, that's an intense emotional experience. There is some variability here, but you can see not as much as we saw in the previous slide. These individuals are relatively stable in this kind of elevated level of loneliness that they're experiencing. And so what we then looked at was whether or not any of these dynamics, other than frequency, are associated with the level of prolonged grief that people are experiencing. And first, just looking at the measures of variability, how much things are changing from one time point to the next, or how much they just are variable in general, you can see that both of these are positively correlated with prolonged grief. So people with more prolonged grief are rating them higher. But if you look really closely, especially at that probability of acute change index, you can see that the people with the highest levels of grief actually show relatively little probability of acute change. The plot kind of funnels a little bit in this way. And I think it's representing this idea that once you get up into this extreme level, people are not especially variable. They're quite consistently very, very lonely. Again, in thinking about the level of loneliness we're talking about, this is every single time we check in with them, 6 times a day, they're telling us they are extremely lonely and that they're feeling that emotional experience. When we look at our measures of intensity and frequency, we again see that frequency is positively correlated with loneliness, but that intensity is even more strongly associated with loneliness. So not just that they're reporting loneliness more often, but when they experience loneliness, they're experiencing it more intensely. So that top level plot, you can see that frequency is pretty consistent with what we've seen in past findings. But I want to suggest that there is a little bit more nuance here than we can get just with our traditional retrospective reports. So this is, at that second visit, we asked people to reflect on the past couple weeks, the time period they were doing the EMA assessments, and asked them to report on the loneliness that they were experiencing. And you can see here that we have this almost kind of normal distribution looking response pattern where it's relatively uncommon to have a never response, it's relatively uncommon to have an always response, and a lot of people are telling us that they experience loneliness sometimes. When we look at our EMA data, we see essentially the opposite pattern, where we have a very bimodal distribution, where some people are saying very rarely, 0 to 20% of the time do I experience any loneliness, and a lot of people are saying they experience loneliness at every assessment, essentially, that we ask them. They're very, very common. And I think what this suggests to me is that there's something being missed in our retrospective self-reports. There are people who are experiencing loneliness a lot of the time that we're missing. And if we look a little bit in more detail, we've now on the x-axis here, we've binned each of our people who said on the ICG that they experienced loneliness never or rarely or sometimes. And then on the y-axis, we look to see how often they reported loneliness in the EMA assessments. And you can see on the far right-hand side, if people report on the inventory of complicated grief that they always have loneliness, then indeed they tend to show loneliness a lot of the time. But if they tell us that they experience loneliness rarely or sometimes, there's a huge amount of variability in how much loneliness they could be experiencing, including the possibility that they experienced it 100% of the time when we asked them in the EMA surveys. And so I think that, to me, this suggests that these measurements are again, kind of missing something. Now, I'm going to skip ahead through these findings here a little bit quickly because I'm running a little low on time. But our next question that we wanted to look at was the relationship between social activity and prolonged grief. And again, whether or not that relationship differs between those with elevated prolonged grief symptom severity. And what you can see in this plot on the left is that individuals with prolonged grief have higher loneliness, just as we've seen already in the other findings. But the relationship between social activity is not different. There is no significant interaction between those with and without elevated prolonged grief. In both cases, when people are engaged in more social activity, there's a very modest reduction in loneliness. Over the full scale of 0 to 100, it's about an 8-point reduction. But by and large, the relationship is the same across groups, and it's very weak. So the effect of social activity is not especially strong. So for me, I think there's a few conclusions to draw from this. The first is that prolonged grief is not only associated with loneliness frequency, it's also associated with the variability in loneliness and the intensity of loneliness that people are experiencing. We also see that the within-person association between social interaction and loneliness is relatively weak. And for those of you that work with bereaved adults with prolonged grief, this might not seem especially striking. It's very common for people with prolonged grief to say, I go to a party, I go interact with people, but I still just feel tremendously lonely. And I think our findings are kind of picking up on that and really making clear that the effort, I think, to help people feel less lonely is going to involve something much more than just getting them to go out and interact with people more often. There's something much, I think, more fundamental that needs to change. I think this also has some implications for how we think about the measurement of loneliness. The UCLA Loneliness Questionnaire, again, is very easy to administer in large surveys, and it's really helpful because of that. But there are some limits, and I think ecological momentary assessment can help with those. And I think this extends to grief as well. That item that we looked at with loneliness, item 19, that same kind of pattern of findings happens for most of these items that we've looked at, where we're kind of pushing people into the middle of the response options and missing, I think, potentially some big differences between people and how they respond. All right. I'm going to skip ahead to my acknowledgement slide. Thank you for the wonderful team that helped do this work. And I'm going to move us right into the discussion because I've gone a little over time. So thanks, everyone, for your time.
Well, first I have to say it's just really fun to be here because I have mentees, collaborators, mentors, mentees who've become collaborators and mentors all in one room. So it's really a lot of fun and great to hear all the work you're doing. And I would just say, it is on one level a bit of a challenge to be discussing. I'm going to keep it relatively brief because you might say these are really disparate talks that are like loosely connected in a certain way around prolonged grief. But I would actually argue that everyone is trying to do a different approach to the same task, which is how do we really understand what makes up and how we identify what prolonged grief disorder is in a condition where everyone who has it has been exposed to a death, which is a universal phenomenon. So how do we really understand and tell what would be a typical grief trajectory from prolonged grief and what really makes that up? So we had starting with a cognitive neuroscience perspective and thinking about some of the key elements that have been part of the discussion and maybe even confusion about what is attachment or avoidance and how do we think about social attachment, and some cool work which Mary Frances didn't even really have time to get into about what's going on in the brain and how oxytocin may influence that. But I think a key thing just to take from her talk is that confusion about avoidance and approach, and that they're actually both occurring, and that you have avoidance of the permanence of the death reminder, but you may not have avoidance of attachment memories or attempt to reconnect. So that's sort of thinking about the reward neurocircuitry and also avoidance neurocircuitry. And then I guess we'll go in order here. As in Sydney's work, she took really a naturalistic experiment, if you will, about how different types of losses may be impacting that trajectory. I think one of the challenges that you faced in your project is that everyone was actually under a substantial amount of stress. And as I think Kathy Shear knows, I like to, and she promotes talking about this as a post-loss stress disorder, but a lot of those impacts that may have been COVID pandemic were actually affecting the entire population. So I think some of the differences between what we might call other natural losses and COVID losses were actually impacting all losses. So it may have been a little harder to see as much of a differentiation than the unexpectedness itself, which may be increasing the traumatic distress side. So probably that's part of what was going on, in my opinion. And probably if you had like a more in-depth understanding of pre-existing stress levels, depression levels, that might have added a little also to your model. And I would say both of our gentlemen over here are using advanced computational methods. They've showed you different aspects of that. And Matteo's really amazing work of taking what can you tell from how someone just simply talks about their grief, which is something as clinicians we have to be super careful, because our data that we have available, at least that we hear, someone having an intense grief response initially isn't going to differentiate. So someone has a severe acute grief in the moment that they learn someone dies, for example, isn't going to tell us how they're going to be doing a year or 5 years later. But somehow there's something that is already possible to pick up in those first 3 months. So I think the fact that you have anything at this stage of the game is pretty impressive. And then I think Don also followed along that theme of really trying to understand how can we differentiate, in this case focusing mostly on the loneliness aspect, which may be also in our kind of stress and response to social isolation side of the spectrum, in a way that also can be confusing as to what is loneliness really attachment and reward, or is loneliness a general stressor response where you see the associations with depression and prolonged grief. So I know we're running long, so I only have time for questions, but I would say all of them are doing really important work that does have a tie that comes together, which is trying to really understand the nature of the condition, and then also how we can predict what factors may contribute to developing that condition. So I think with that, we want to use any last 5 minutes maybe that we have for other people to be able to ask questions. So I will stop there. Does anyone have questions or even comments? Eric must have a question.
I have too many, so I well, I have many, but maybe the broader thing is, I think so they're all connected through attachment, and actually that's so basically that's what is reflected there, the attachment with the person, attachment figure. And there too, with the loneliness, so you can see 20,000 people, but if you don't have that attachment relationship that is gone, then you feel lonely, because you don't have that. So that's what's missing, and that's a feeling of loneliness. And I think in both your talks, it's there, and it's not explicit, but it's there. That is what is grief. I feel. That was a comment. That was
Yeah, come on up.
But the question maybe overall, like, so all the tasks, or the several tasks, the question I had that kept popping up is, what would it look like pre-post treatment? In terms of your task, or in terms of the speech, in terms of the EMA. Because Don, when you talk about the EMA, so I agree with you that we're capturing something different, and we have an objective measure of how much people suffer, but at the end of the day, they're in front of you, and it could be the other way around. They could tell you, I feel extremely lonely, and you do have data showing that, no, you actually you don't feel that lonely. What do you do with that? So I don't know if so I guess the two thing is, how would successful treatment impact those variables, those tasks? And And even if we have objective measures, would that change that much what we're doing? Because we're still in front of a patient with their complaint or their chief complaint that day in front of them.
Does anyone have a response?
I am very curious to hear other people's response, so I'll keep mine short, but just because Dr. B put me on the spot with my EMA assessments, I think that I don't know how people would change over the response in their EMA assessments. We've done a little bit of this work, but I think not enough to feel really confident. But generally what I would say we see is that the responses on the EMA seem to change less than what we see in traditional self-report and clinical interview measures. Now, that could be, as you say, that people are experiencing their life in a different way that's showing up in their subjective reports in those assessments, and that we're failing to capture it in the EMA assessments. There's some broader like metacognition about their lives that has shifted, and I think that's one really valuable possibility. I think another possibility we kind of have to own is that when people are sitting in front of us and we're asking like, did this treatment work for you, they might feel some, motivation to tell us that, yeah, it was really helpful, and that we might, have a sense that these EMA assessments are giving us a clearer picture of how things are really changing in day-to-day life. So I don't know for sure how it would play out, but I think it would be really valuable. But I'm also really curious to hear what other people think.
Just to sort of repeat the question for the virtual audience, Eric's asking sort of pre-post treatment, how would some of the results look different for these different tasks that Don was giving us? Really, yeah. I mean, of course, partly it's an empirical question, but I think, and not one that I have an answer to for the task around the approach avoidance. But what I think is notable to that is, in therapy, we're very focused on sort of having them think about the loved one or recall memories with the loved one, or around restoration of life now, so maybe bringing in a living loved one and so forth. But what I find fascinating is that with that PGD group, they're more avoidant to everything. And so I think, could there be something pre-existing there that kind of predisposes them maybe toward PGD after the death of a loved one? And maybe that individual difference variable doesn't have to change, but that's sort of getting into the idea of how do we predict who is going to have the toughest time, so to speak, as early as possible so that we could intervene. So that even if they are doing better, they may still be an avoidant person, is sort of an interesting question.
And since you have the mic, and I was also wondering if you had any measure of pain, because with the oxytocin could we alleviate pain, and so that might correct some of what you.
Yeah, we don't have pain in the sense of, we didn't ask it that way, but we did ask about anxiety, state anxiety. And interestingly, the oxytocin did not show any differences. I anticipated that we would have to control for that, but actually they did not show less anxiety with oxytocin than they did with saline. Interesting.
All right, I think we are a couple minutes over, so thank you everyone for being here. We'll stay up if anyone has any questions, but thanks for being such a great audience.
Great job.